When working with individuals that have experienced or are experiencing thoughts of suicide, there are different things to take into consideration when working with special populations, particularly children and individuals with developmental disabilities. According to the Center for Disease Control and Prevention, in 2016, suicide was the second leading cause of death for children ages 10 through 14. Keeping this in mind, we can better understand the importance of normalizing suicidal ideations, not only for the child's benefit, but for the caretakers as well. When we talk about normalizing suicidal ideations, what we really want to work to do is to remove the stigma attached. We want to help the child and the caretaker both understand that they're not alone. If a child is experiencing suicidal ideations for the first time, it can be a really scary thing, it can be daunting, and they can feel like they're alone. We want to work to let them know that it's not bad or wrong, that they're not in trouble, and that there are resources and people that can help. Similarly, with caretakers, we want to reassure them that there are resources and people that can help them as well. When caring for a child that's experiencing suicidal ideations, if the parent or the caretaker doesn't have any prior experience with this, it's important to normalize that for them as well. A good way to keep everyone on the same page when working with children experiencing thoughts of suicide is to keep the caretakers involved in the safety planning process. Doing this works to ensure the continuity of care once the child formulates a plan with a helping professional and then goes home and it's time to put that plan into action. By keeping the caretaker involved, we can work to not only identify triggers that might precipitate suicidal ideations, we can identify factors, contributing factors, as well as coping skills that can be used during crisis situations. Having that caretaker present throughout this planning process can help with accountability, follow-through, and support. It can help the child feel like they have somebody on their team once they get home. In addition, by involving the caretaker, we can also work to make home environments safer for children by reducing access to the means. An example of this might be a child who identifies their depression medication as a means for completing suicide. They might have a plan to overdose on the medication that they take every single day. So by involving the caretaker, we can create a plan that involves the caretaker keeping hold of this medication and distributing it, helping the child to understand that it doesn't mean they're in trouble or that we don't trust them, but that this is a way to keep them safe. In addition, it also allows the caretaker to feel like they have more control over a situation. Those with developmental disabilities have a higher likelihood of having risk factors for suicide when compared to the general population. When assessing individuals of the specific population, we want to be sure to ask directly about thoughts of suicide or killing oneself. Clear language is extremely important when assessing for thoughts so that we know we are communicating as clearly as possible with this individual. More research is needed regarding recommendations for the language that should be used when working with people with developmental disabilities and assessing for risk and discussing suicidal ideations. There have been many assessments created for working with this population that asks questions about urges to self-harm or self-injure, but not about suicide. Therefore, it's important to be direct in the language used. Although it's important to assess not only for thoughts of suicide, but for urges to self-harm as well, it's important to differentiate between the two and understanding that assessing for urges to self-injure is not the same thing as assessing for suicidal ideations. One thing we can do during the assessment process to make sure the information we obtain is as accurate as possible is to include the primary caregiver in that assessment process. By involving the primary caregiver when working with an individual that has a developmental disability, they can help because they may be able to offer additional insight or important information that the individual did not mention on their own. However, taking this into consideration, it's important to realize that suicidal thoughts and behaviors may not always be fully recognized by the primary caregiver. So we can't utilize this as the only source of information, but it can be a helpful addition. Taking that a step further, it can be beneficial to include the primary caregiver in discussion for safety planning. By having that primary caregiver present, we can ensure continuity of care once that individual leaves the presence of the helping professional, and that can help with accountability and follow-through once that individual returns home and has to put that plan into action. When looking at treatment options, the first step in treating someone who is suicidal is making sure that they have access to a mental health professional. Professional support and structure are especially important when working with someone who is experiencing thoughts of suicide in any capacity. Suicidal thoughts may be a symptom of a larger mental health disorder. Therefore, it's important to connect individuals with a mental health professional so that this can be properly diagnosed. When looking at treatment options, it's important to recognize that there are two different sides to hospitalization, the first being voluntary. Voluntary hospitalization most often occurs when a helping professional may be working with an individual who identifies that they are not able to keep themselves safe in that situation. Hospitalization provides intensive treatment in a controlled setting. There's different levels of hospitalization as well. For example, partial hospitalization. This is where the client returns home in the evening, and it can be less disruptive to the client's life, as well as helpful with the transition from full hospitalization to returning home. On the opposite end of the spectrum, we have involuntary hospitalization. This is hospitalization that's done against someone's will, where the priority becomes safety. Typical criteria for involuntary hospitalization includes when someone is a threat to themselves and/or others, as well as marked symptoms of a serious mental illness. The average hospital stay is approximately 96 hours, but this may be extended based on presenting needs. For further information on how to initiate this process, check out Missouri's laws for involuntary commitment. It's important to understand that individuals discharged from the hospital for suicidal ideation or behavior are at an increased risk for suicide. In fact, the greatest risk is in the first 24 to 48 hours after leaving the hospital. Risk for suicide is 100 times greater for individuals post-hospitalization compared to the general population. It is extremely important not to assume that client's suicidal crisis has dissipated. This is why post-discharge follow-up is crucial.
Dialectical behavioral therapy, or DBT, is a therapeutic intervention developed by Marsha Linehan initially as a treatment for individuals suffering from borderline personality disorder. Recent research is showing that DBT can be used for a wide range of concerns outside borderline personality disorder. These include, but are not limited to, substance use disorders and eating disorders. DBT is shown to significantly reduce frequency and severity of suicidal ideation. DBT consists of 4 main components: individual sessions, group skills teaching, coaching calls, and a consultation team for the therapists themselves. In individual sessions, the therapist seeks to help their client integrate the skills that the client has learned in skills teaching groups into their personal lives. Within the skills teaching groups, clients are taught the skills of mindfulness, distress tolerance, emotion regulation, and interpersonal effectiveness. Coaching calls are a unique option where a client within DBT treatment has the emergency numbers for their therapist as well as the other therapists on the DBT consultation team. Clients can reach out for on-the-spot coaching of a skill they can use during a difficult life event or crisis. The DBT consultation team allows the DBT therapist to work together to protect the other DBT therapists on the consultation team from burnout. They collaborate with each other on problem-solving client issues. They teach each other DBT skills, and then they assist each other with answering coaching calls of their DBT clients.
Cognitive behavioral therapy, commonly referred to as CBT, is therapy designed around behavioral and cognitive change. The word cognition is defined as the mental action of acquiring knowledge and understanding through thought, experience, and the senses. CBT is a goal-oriented psychotherapy treatment that works to change people's patterns of thinking or behavior. The focus is primarily on the relationship between thoughts, feelings, and behavior. CBT stresses that these 3 factors, thoughts, feelings, and behavior, work in a triangular fashion, as one affects the other 2. When using CBT with an individual who has experienced suicidal thoughts, it works to build upon client learning to recognize those thoughts, and then promote use of different tools to combat negative cognitive or behavioral patterns. The therapist and client really have to work together and collaborate in order to facilitate change using this modality of therapy. Sessions can be administered in as little as 5 weeks. However, it's common for individuals to attend anywhere from 5 to 20 weekly sessions. The length will depend on the severity of the presenting issues and will most likely be determined by the individual and therapist based on factors such as needs, progress made, barriers, the client's environment, etc. There are so many resources available, but it's important to know that there are other options in addition to hospitalization. Hospitalization is not always the best plan of care when working with an individual that has experienced or is experiencing suicidal ideations. Additional resources include not only local crisis lines and the Suicide Prevention Lifeline, but different services, such as mobile outreach services and walk-in crisis services. Mobile outreach services include trained professionals that can pre-assess for hospitalization and connect the client with appropriate resources. Walk-in crisis services offer immediate help without requiring a hospital. However, they do recommend hospitalization when necessary. The bottom line is that there are many options to choose from, and it's important to educate yourself about the resources available to make sure you're able to connect an individual with the best option for them.